to another exciting, unscripted episode of Coffee, Compliance, and Chuckleheads with my two other favorite Chuckleheads, Sean Weiss, Eric Rubenstein. As always, happy to be with you guys. Tons of stuff going on. The most exciting thing for me right now is we're getting some cooler temperatures here in the South, baby. I'm liking it. It feels better outside. As a smooth 53 degrees this morning.
Yeah, we actually had some very cool weather here over the last couple of days for the beginning of spring in South Georgia. We were in the mid 50s throughout the early part of the morning into the mid morning, and then we hit uh, nothing higher than about 78 or 80 degrees, which was extremely pleasant.
I can't keep up with Eric. Eric, it depends on what side of the coast you're on, up or down, as to your
There it is.
temperature gradient here.
I'm down to I'm in Orlando today where it was a balmy 92 and it's been raining for about 2 hours. I am going tonight to see the Killers at the Amway Center, and that is indoors. I am really hoping it doesn't rain tomorrow because we're seeing the Chili Peppers and they're playing at an outdoor venue. So I'm really, my fingers are crossed that it doesn't rain tomorrow.
Yo, man, always on the move, always on the move. Well, it's kind of as always, we have a jam-packed show here, a lot of things going on, and we're gonna kind of skip around. We'll move around here a little bit. I want to start with just a few things. We've had some things that even occurred today. So prior auth has continued to be a big issue for a lot of people in most service lines. There was a bill that was introduced last year, was HR 3173, which was the Improving Seniors Timely Access to Care Act. And of course, everything moves at a snail's pace when it's going through the bill process and passing process, but it was introduced back in 2021. The House did pass this bill just about 2 hours ago, I believe. So this is a good response. Again, it's not an end all be all, but it is a step in the right direction to reform kind of the broken prior auth system that we know exists today. And this would hopefully extend beyond CMS, but also to commercial payers. And not only that, it was for our seniors, so those that we would classify as 65 or above, but hopefully we'll see this trickle down into just prior auth in general, as several other research studies followed this passage, and we can get those out if anybody has any interest in them. But I know, again, for a lot of the clinical people, the administrative people that tune into the show, we appreciate you and we understand the prior auth headache, and Sean, myself, and Eric being on the patient end of things. Also understand the frustrations of when prior auth is needed in the confusing process. So there is that. And other kind of big news that I found was interesting in the midst of all of the turmoil with staffing and supply chain issues in healthcare, we had the 1,500,000 nursing or nurses strike in Wisconsin. It was interesting because the seven healthcare providers that this strike affected were very, very large providers. But in this strike, it wasn't really about the financials. It was really about the frontline providers, the nurses, being able to help write some of the regulations and set the boundaries of the regulations when it came to staffing ratios and things like that. So to see the organization, and of course we know that the nursing population is the largest in the healthcare, I mean, of any other specialty. But it was very interesting because, this comes on the heels of several surveys that they did that showed, just last year, they said, 19% of nurses that were out there planned on leaving the profession anyway, just due to because of some of the issues. And I will tell you, it seems like as long as I can remember, there's always been a nursing shortage. Like there's never been, hey, we're at capacity with nurses. We have adequate staffing, no problem here. I don't think I ever remember that time that was the case at all. So, what made this case interesting was on Sunday, the governor actually stepped in I think Tony Evers was the governor, and essentially there was a bill that was put into place. They called it Act 10, passed basically 11 years ago, and it basically said it attacked kind of the most public sector labor groups in Wisconsin, but they removed UW Health from having to recognize unions and negotiate pay and working conditions. And so that's really what all this kind of stemmed from. And the goal of the nurses was to get hospital administrators to the actual meeting and to be able to sit at the table to go over some of the issues that were pressing to them. And hopefully, based on whatever decision comes out of this, that they get this rectified, the other states will take a look at this, because we did get wind today that several other states, nursing groups and societies, organizations, were looking at doing the same thing. So, any thoughts on that from you guys?
Well, for me, obviously, I hope that the administration or administrations listen to the requests and concerns of the nurses. We cannot allow ourselves to fall deeper into a trench where we have less available healthcare providers. I think we talked about this the last time that I was in the hospital, about 6 weeks ago, when I had that robotic surgery for my abdomen. You know, they were so short-staffed, nurses, and it was apparent. I mean, medications that were supposed to be given at 7 o'clock at night weren't given until 10 or 11 o'clock at night. And I'm one of those patients where I will not press my call button unless it is so significant, because everybody knows my wife up there and they will tell on me. And you both know my wife very well, and I just don't need any more problems than what I've already created for myself. But
You mean you're
you
not?
know,
You mean
to
you're
your
not
point,
pushing your? You mean you're not pushing your call button for a George Costanza sponge bath?
no. It's usually, hey, can we take this from 1 milligram to 2 per 7 minutes on the PCA pump?
That's right.
But but the thing is, we've got a broken industry in so many ways, right? Whether it's operationally, whether it's clinically, whether it's enforcement, talking about the law enforcement aspect of things, prosecutorial misconduct. It's really, I feel like, even though we're in 2022 going into Q4, I feel like I'm back in the 80s or early 90s, where it's like the Wild West, right? And Eric, you're older than me. So you should be able to relate to I would have said Jordan, right? But Jordan was still in diapers while you and I were, cutting our teeth
That's
in
right,
the
man.
80s and 90s. But
That's true.
in
That's
all
true.
fairness, but all kidding aside, I feel like we're back in the Wild West, and it's highly concerning to me, because not only do we have a shortage of physicians, we have less and less people wanting to go into the medical profession. And, as a result, what is that saying? And I always love when one of my favorite people in the world joins us,
Here we
because
go.
she just drives it in a little bit deeper for me
Yeah,
every
I
single
know.
time. I love
It's
it.
funny.
But
Just
Eric,
when
I
you
know you
think,
got some thoughts on this.
just when you think you've hit rock bottom, Jean Marie Loria takes out a shovel and starts digging for you. First, yeah. So look, I think the thing is, first of all, COVID-19 obviously did a tremendous disservice in the nursing world, right? By not providing waivers for nurses who had a previous exposure of COVID, and this entire mandate of the vaccination and what have you. And now you see that the vaccination mandates no longer exist anymore, and not in an effort to make this an argument either or, but you've got a group of people who lost their jobs because they didn't get vaccinated, or there wasn't an impetus for them to be able to say, hey, look, I had COVID, check my antibodies. How is this any worse or any better? But now you've got people that are soured from the profession and have left that traditional world, and nobody bothered to go back to them and say, hey, come back to work, right? Like, so we here at Advise, we just hired a nurse who got laid off from her job because she put in for a religious exemption for to not be vaccinated, and lost her job and said, well, I'm going to go reinvent myself. And she did. She went out, she became a CPC. So she's an RN CPC now. And, at no point was she ever asked to come back to work where she is. The other thing that's come to mind, and this only came to mind recently with a few things, is this concept of the RN compact license, right? So more and more states are jumping on board with that. And for people who don't know what that is, if you have a valid nursing license in one state, you may have actual reciprocity in a number of other states. The number keeps growing. I actually was amazed. I went on today and saw that New Jersey has signed on to be part of the compact licensure, which was something that really surprised me because New Jersey doesn't have reciprocity. New York, New Jersey, a lot of the Northeast states do not have reciprocity with a lot of other states for a lot of things. And so looking today and seeing that New Jersey got into the compact license, I think that one of the factors now is going to be, as there's a migration of people away from certain portions of the country to other portions of the country, are we going to see this like recalibration? Nursing shortages that occur in one place may not exist in another place. And I think that there's a little bit of an argument to be made that when you've got nurses going out and striking for these, things, that's part of it. Just look at some states when you talk about NPs and PAs, where they do not need a collaborating physician. In some states where they can operate, and it's limited, right? It's not like they can go in there and do major surgery, but I remember reading something not recently, but a few years ago, where when the Affordable Care Act was looking to provide some bonus money for nurse practitioners and for physicians' assistants to go to school, one of the things that I recall reading was that something like 85% of medical conditions that are seen in the office setting are routine services that can be treated by an NP or PA. So, you see now, for example, the Minute Clinic, which was around for years, is making a comeback.
Right.
I just talked to somebody the other day who just relocated to New Jersey from California for work. His wife is a nurse practitioner, and she's going to be running a Minute Clinic. And I said, oh, I thought those didn't exist. Well, they're coming back. So, I think there's a little bit of this reorganization, this reinventing of people that are in this non-physician practitioner and nursing world. I recently had a family member who was in the hospital for a hip replacement, and every single nurse that came in who asked about what we all did for a living all said, can I give you my resume? Like, they all want to get off the floor. And that was something that I think 20 years ago, you never heard of that, right? Nurses got into nursing because that was the job. So, when you start to see these things happen, it's going to have a trickle-down effect. I think what would be great would be seeing this expansion of the compact licensure to allow nurses to be able to move from one state to another and be able to get that employment. But also, I think that there really needs to be a push to bring back that core competency of what nursing is, and that it really isn't being the lapdog to the doctor, for example.
So Sean brought up an interesting point, and I think this is keep your eye on this ball, because the comment period for the proposed rule is coming to an end. And I can just tell you, I read those when those get posted, clearly, because I have nothing better to do with my time. But we go to the website and we read, and there is not much opposition or not many comments being made. We were expecting some of the large organizations and societies, especially radiation oncology and some others, to make a stance. They did not. Their letters were submitted for OPPS. And basically, under that supervision, this would allow for nurse practitioners and others to supervise what was primarily always done by the physician. And to Sean's point, what are the ramifications for those physicians that have stuck around? We don't really know, but we can likely infer that this will affect reimbursements. It also changes the dynamic that if we allow this for OPPS, we're not going to allow it for the freestanding based on the way that the rules are written, meaning For a hospital, they would have an astronomically large advantage to say, okay, I'm a hospital, but I have 7 outlying clinics. So instead of having to put physicians at those outlying clinics, now technically by the rule, if it goes through, and like I said, some of these comment letters we were expecting to see some opposition and pushback from are not coming through as any opposition or pushback. It's just simply they're not mentioning anything about it, but it would allow for that coverage. So I respect the physicians. I respect what they went to school for. I think the physicians are not going to be happy as a whole if this happens. Now, a lot of people have called me already today because we did not see the opposition in some of the letters that were sent, and they kind of ask why. Right? Well, remember, a lot of physicians are employed. There's by the hospital system, so maybe they, some feel that things are locked in. The freestandings are the guys that are really pushing back because we all know that some of this care is less expensive to be given outside of the hospital. So lots of things to watch over the next few months as we get into the final rule. But this is one of the things: supervision in the OPPS setting, hospital setting is going to be a big focus for a lot of people.
Real quick,
Go ahead.
if I could, I wanted to go back to something, to a point that Eric was making about nurses becoming soured to the industry. I think is the term that you used, and
Good term.
I think it's an accurate term. I think it's a fair term.
Very.
We do our best to remain apolitical on the podcast. But it's hard when you see politics driving healthcare. And what I mean by that is the same people just a couple of months prior to this whole vaccine, whatever you want to call it, okay, these mandates, these individuals were all heroes. They were all revered. They were all well respected. People were looking at them and I mean, you couldn't go out without somebody thanking them for what they've done. And then all of a sudden, they became the enemy of the public because they were on the front lines and they knew better than what the policy wonks sitting on Capitol Hill or those who had never practiced medicine a day in their life at the CDC or the NIH trying to push out a narrative for why you should get a vaccination, only to find out later that the vaccinations didn't protect you against getting COVID. And now all of a sudden, all of those mandates that just a few short months ago were absolutes have all been pulled back. And the funniest thing that that I look at is the state of New York right now. Yep. The governor is fighting for her life. Hochul, right? I think is her name, Kathy Hochul. She is fighting for her life up there. And what did she do? She's allowing the public health emergency to expire for the state of New York because that's the only thing that she has left. So I'm sure I'll get some blowback on this, and I'm okay with it, please, because this is my opinion, not Eric's or Jordan's. But it's time that we start to respect our physicians, our non-physician practitioners, our PAs, our NPs, our CSWs, our LPNs, our RNs, our compliance professionals, our administrators that have continued to support patient care, have advocated for the patients. It's time to go back to showing them the respect that they deserve because they didn't deserve what they were turned into. Jordan, there was a question that was asked for you, and I'm going to stop right there. So if anybody has anything derogatory to say, send it to me on a direct message. Right.
Yeah.
Jordan,
I got that question. So, Al, I know they have not sent their reply. I think their reply is due. It'll probably be by the end of this week or next week, and it will be interesting to see what they say, especially now that we know that the silence has come in from the main body, and they did not say anything. So it'll be interesting to see kind of how that works. And I mentioned that kind of segues into, we had just talked about the freestanding versus the hospital. And I found this to be pretty interesting, that the COA, the Community Oncology Alliance, did a report, released a report. It's just starting to circulate. I think they released it yesterday. But essentially, what that report showed was they did a study. So, again, the data is just the data, right? On these 340B hospitals. So, where 340B allows hospitals to get drugs at a cheaper rate. And this report showed that, based on the assumption that they were receiving, a 34.7% discount on the average sales price of the drug, these hospitals were marking up the oncology drugs that were studied. And it was a list of 20 drugs, was 4.9 times the hospital's actual acquisition cost. So the range was pretty wide. So for one drug, the leukemia drug Camara, was 3.2 times. And then Faslodex, which is for breast cancer, 11.3 times. So, a lot of us look at this and we're thinking, we've been saying this from the beginning, that some of this care, 340B is great, but if they're going to continue to mark the cost of these drugs up, to simply just increase, their margins, is it really helping anybody? And, the data is the data. We keep always go back, to the data, right? And so I found this to be very interesting. Probably the one drug a lot of people have heard of is Herceptin. And they talked about that. And they said for a 340B hospital treating just a Medicare patient, the drug is purchased for about $43,000. It's reimbursed at $70,000. So, 26,000. The margin is $26,000. So, we have to get some level of cost control. And even though we're giving these breaks, are we giving the breaks to the right people, especially site of service of where these things are being delivered? And, what populations are we serving? So keep an eye on this report. Again, it's Community Oncology Alliance. If anybody wants to look at it and you want to Google it, I'll stick it in the window. That way you guys can take a look at it. And then I think I possibly may have been living in the dark ages, guys, because Eric and Sean clearly are going to know about this, but HRSA has what's called a lookalike hospital. And I'm thinking, when I first saw this, I'm like, what the heck is a lookalike? Like, this is like Halloween. I don't know what the heck's going on here. I mean,
so they'll call them FQHC lookalikes.
yes.
So FQHC lookalikes basically do all of the things of an FQHC minus the funding, which is crazy. So they sign up to get that, but they don't get they got the same rules. They got to do the same things, but they do not get the funding stream that you get from a HRSA FQHC.
So, and that's what I was looking
at.
I
can't believe you didn't know that, Jordan, being in Mississippi, man. You got those all over the place.
So yeah, so I knew we had the critical access, the FQCHC, but these lookalikes, and then it started to make sense, because as I started to look at this report, basically, which hits Mississippi us right in the face, right? It says hospitals are outsourcing all this often unprofitable outpatient service for their poorest patients by setting up independent, not-for-profit organizations to actually provide this primary care. And that's what this look alike. And so in going through all of it, like Eric just said, essentially doing much of the same work, but then they just don't have some of that federal benefit. But I mean, they're reimbursed and everything. So, my question is, if the focus is on such primary care and rural medicine, is this area really going to be one that grows? I don't know, Eric, you have some experience in this. You really know about it. I don't know. I'm just would be interested to get your take.
So what's interesting is that, the FQHC and the 340B things go hand in hand, because most of the people that are going to a federally qualified health center are indigent people, and 340B, which is sometimes known as penny pricing, right? So what happens is, if a manufacturer wants to participate in Medicaid and be on the formulary for Medicaid, they must also join and be part of 340B, but it's really very highly unregulated, right? So there's issues on the pharmacy side with mixing medication, and you're supposed to keep separate inventories, and you're supposed to be able to give rebates back, and there's a whole issue. But the thing about FQHCs is it's not just for rural communities, it's for underserved communities. So, you can have an FQHC in downtown Newark, New Jersey, because it's who you have in your population. But the FQHC lookalikes are interesting, and I don't know a ton about them. We've done some work here at Advise with them, some audit work with them. But the big thing is that those centers, they don't meet the qualifications to be an FQHC, but they are billing and doing all of the things that an FQHC does. And I guess it kind of gets a little murky on how they all operate. But you're not going to work at an FQHC and making $300,000 and $400,000 as an internal medicine provider, right? There's going to be some limitations, caps. There's boards that oversee it. Most of the boards are volunteers. The one that I dealt with, all of the board members were older people who were volunteering their time, and it was really sort of just it's an altruistic thing.
It's funny you mentioned the board of directors, because it said lookalike health centers are overseen by a board of directors, and at least 51% of the directors are required to be patients, just like full-fledged community health centers. So it's very, very interesting how things were kind of structured. And you're right on the location. I mean, in going through this list, like Beverly Hills in California has one. So it's not just the indigent areas. It's about the population served in that area. So it's pretty interesting.
Well, when you roll up in your when you roll up in your Cadillac or
your Maybach.
Yeah, or your Maybach, you're showing up for your penny pricing drug.
But it's really interesting, because we have seen a dynamic shift around the country in the most affluent areas being infiltrated with homeless populations, with these individuals that have led to crises in these areas. And I mean, look at Portland, look at Seattle, look at New York City. I think you're going to see more and more of these lookalikes popping up, because the hospitals, that they can't serve all of these patients, and they're looking for a way to offload. I know that's not the nicest term, but they're looking for, I think you all know what I mean. They're looking for a way to offload these patients so that they can receive the care that they need without taking away, vital resources or limited resources of the hospitals themselves. And I think you're going to see more and more of it. And I think it's very interesting. We've done at Doctors Management, we've done a ton of FQHC work over the years. And, you're right, Eric, to your point, in FQHCs, in the lookalikes, the compensation models that you see there. I mean, top end doctors are making $75,000 to $80,000 a year working in these facilities. So you're not doing it, to get rich. You're doing it because you have a compassion for the patients.
So interesting. Two things real quick is you have to wonder if some of these centers are going to pop up in these more affluent areas and be affiliated with hospital centers, so that the hospital center doesn't get accused of an EMTALA violation, right? A patient dumping. Hey, you're here at the emergency room. Our clinic is next door. It's affiliated. And so we're going to walk you over to that clinic. Does that get them around a patient dumping case? I don't know. I haven't thought about it. This is just us talking, but it is an interesting premise that there may be an attachment. What is interesting, I'll tell you, is I had a case when I was an OIG agent with an FQHC that was in Newark, New Jersey, and three of the providers, two MDs and a nurse practitioner, I arrested on kickback cases. All of them were part of a very large case that I worked on, where about 20 providers were charged around New Jersey for taking kickbacks from an MRI center in the area. And these three people were convicted. They pled these three happened to plead guilty. They all got adjudicated, all did a little bit of time. And one of them went back and got a job back at the FQHC. Now, there was a whole issue. She wasn't doing patient care. She was excluded. She was doing training and education. The problem was that the FQHC had such a difficult time hiring people that they said, look, we can't have her doing patient care, but we're certainly going to have her help with doing training and education of the providers. Now, there was a whole other issue involving, there was an exclusion issue, and the FQHC had to pay some money as a damage, which was a very painful thing for us to do because the FQHC had no money to begin with. You had 3 doctors who were taking kickbacks as a result of probably their lack of being paid to begin with. And then you throw in the fact that at the end, one of the providers, after getting out of jail for 3 months, goes back and works at the FQHC. So, it's a challenge all around. And I think that this just goes to show you that the constant social determinants and social detriments to healthcare are going to be there for these, for certain populations of people.
Well, it's just interesting, right? We used to write it off as like bad debt, right? In the hospital, it didn't have any other way around it. So it's bad debt. And now it's like, well, maybe you can spin up. It's like, there's always this magic answer, right? Spin up the lookalike and maybe you can serve a population and then still be reimbursed for it. So, and KHN is the one that did the report on kind of how some of that works. I know Sean's posted some of the links, and I'll send Sean one more of the actual KHN lookalike report that they did, and he'll post that. But yeah, that about covers like the latest updates and kind of news of what's out there. And then I think we should shift gears. I mean, obviously, as we get into the final rule season here, the final stretch to the final rule, telehealth, telefraud, television, whatever you're thinking, Eric, on this fraud, man. I think it's just what the OIG and some of these others have said is a little stretch, but I think we should at least cover it. Eric, you want to touch on your stuff?
Yeah. So, the big thing for me, and we've been talking about this offline for the past, give or take a week or so, is, the recent OIG study that came out. It actually came out from OE&I, Office of Evaluation and Inspection, came out just a few weeks ago. It's a September study that they did where they took a little bit of a deeper dive into telemedicine and into some of the indicias of fraud, waste, and abuse. They looked at a large number. It was something like 722,000 providers during the course of the pandemic, had submitted claims for what amounted to a telehealth visit. And they found that of the 700 plus thousand, only about 1,700 were involved in some indicias of fraud. And I'm just gonna pull this up so that we can all see it, because they actually listed 7 things that would be some of the indicias of fraud, waste, and abuse. And what kind of amazed me when I looked at this was that these are things that are indicia of kind of all fraud, waste, and abuse from a program integrity perspective. So, seeing that a telehealth visit was billed at the highest, most expensive level, a level 5 every time. Well, that's not a shocker. Of course, that's an indicia of fraud. Billing telehealth services for a high number of days in a year. They identified 2 providers who happened to be affiliated with the same group who billed for 365 days, in the given year. Billing a high number of hours relative to telehealth services. I don't know what a high number of hours is because no one ever really defines it, but it's, typically it's greater than 12 hours or something like that. And then, billing a high number of beneficiaries. But, the one that really stands out to me, which always kind of gets my craw, is this billing for telehealth services and ordering medical equipment with a high percentage of people. That one is the one that kind of sticks in my craw, because there was a previous study that was done which said, I can't remember if it was 84, 86%, but whatever that was, it was either 84, 86% of the Medicare population used telehealth during the PHE, which meant that either 14 or 16% had a previous relationship with their provider. Sorry. So they used telehealth and had a previous relationship, which means that either 14 or 16% had no prior relationship. So the question is, what's being done to identify that 14 or 16%? Are those people who took advantage of a new patient visit for whatever the reason was? Is it a legitimate service or whatever? But the problem with this is that there's a website that I found today which wrote an entire article in which they essentially say, and I'm not going to show the website because I really don't want to support them on this, but the website the website's title, the article's title is OIG report suggests telehealth fraud is rare in Medicare. And what they're relying on is the fact that they looked at 700,000 people, 700,000 providers, and 1,700, right? So 99 point whatever percent of the provider population were not reflective of indicia of fraud. Now, I think that there's some flaws. Number one, I think the number one flaw is, why is it that we're seeing billion-dollar genetic testing, DME, frauds that are all related to telehealth, right? So no prior relationship, none of that, right? So the question is, they looked at the 700,000 providers who submitted a claim for a telehealth visit. So there's going to be some inherent issues with those providers, right? So they narrowed it down to the 1,700 in which there was a questionable number of hours or what have you. But the bigger question is, what's the number of providers that are listed as the referring provider for a genetic test or for DME in which there was no prior relationship with that patient? And I'm going to guess that that number is going to be humongous. It's going to be a different number than that 700,000, because 700,000 is the universe of providers who submitted a claim in which something on the claim was reflective of telehealth, whether it had been early on the GT modifier or the modifier 95, which is on there now, or during the PHE, the CS modifier, which allows you to get the full payment for the E&M, right? So a lot of these are going to be CS 95s or at least 95 modifier for the telehealth. And so, I think really the next iteration that we should hopefully see, fingers crossed that we would see, is some analysis of instances during the PHE in which an item, service, or procedure were billed to the program, but the referring provider had no prior relationship. So I think this study was a great study in the sense that it looked at, it came up with the 7 metrics, which are not a mystery to anybody. But I think that, when we look at an article that says that OIG found that telehealth fraud was rare, is a little misleading in its article, like clickbait. Sean, I know you and I talk about this like incessantly. So
Dude,
we do. And I agree with you. And I want to share this document. I know, Eric, you've probably seen it. If you haven't, here it is. So this was a special fraud alert that was issued by the Office of Inspector General to alerting practitioners to exercise caution when entering into arrangements with purported telemedicine companies. And even though we are at the end of the public health emergency, folks, these audits are going to be going on for the coming months and the coming years into the relationships between practitioners and these telehealth or telemedicine companies to ferret out fraud, waste, and abuse. Because billions and billions of dollars were spent during this public health emergency, and the government is going to claw some of this money back. And, one of the common elements to the schemes for these telehealth service companies were the way that they use kickbacks to recruit and to reward physicians or practitioners to further the fraud schemes. We had providers. I want to be careful. As many of you know, I'm an investigator and reviewer for medical boards across the United States. So I got to be very careful on what I talk about. But I will tell you, in the last few months, I've had a number of providers that were escalated by the SIUs of the different insurance companies, where all of a sudden the number of prescriptions for DME for these providers who never prescribed, or if they did, it was very rare, their numbers were exponentially increased. And what does that do? It throws up a flag to the insurance companies, because again, what do they use? Data mining, data analytics. They look at historical billing patterns. These are not things that I am, these are not things that are uncommon, right? So, a number of providers actually, when they were interviewed, openly admitted that, look, I never had a relationship with the patient. I never, you know, did an initial evaluation of them. And I thought I was only signing off on the orders of another physician, kind of like I was doing a secondary. Folks, if a physician or a nurse practitioner or a PA has the authority to write a prescription for DME or for a drug or a biologic or a diagnostic test, they don't need you to sign off as a secondary. I mean, come on.
Yeah, that's just nonsense. So interesting that you say that, because the very last arrest that I ever did as an OIG agent was on a doctor who, I jokingly would say it's amazing that he didn't get carpal tunnel from all of the prescriptions and orders that he was signing. And what this guy was doing was he was signing off on orders for DME and for compounds. And what he was doing was he was getting them from a telemedicine company he was hooked up with. He got paid $25 or $30 per prescription. And what was going on was they were actually putting his phone number on the order. And so patients who had never met him, didn't know anything about him, some actually thought, when I interviewed a lot of the patients, they said, oh, I thought that Dr. Smith was working with my doctor, and for some reason my doctor couldn't sign the prescription. But I got this knee brace and I didn't have a problem with my knee, so I thought that was kind of weird. And what's interesting is that at one point the doctor is getting so many phone calls from people complaining that he sends an email to the telefraud company that he worked for and said, take my phone number off of these orders. I don't want people calling me. They should be calling you as the company. I mean, if that's not a great email, that was there's not a lot of smoking gun emails in the healthcare world, but that was a fantastic one, to see that he wrote an email like, these people are calling me. I'm not paid to consult with them, is what he basically said. I'm paid to sign these prescriptions. And the problem with these is that in this environment that we're living in, when you're writing an order for a fraudulent prescription to make the money for a patient that doesn't otherwise need it or may have an adverse effect from it, they get that prescription and they don't know. And the one example I always love to give is that in the compounding world, gabapentin, which is a nerve medicine, also known as Neurontin, but gabapentin has some toxicity levels with it. And gabapentin is a medication that was included in a lot of these compounds for pain meds, these pain formulations. And, on more than one occasion, I interviewed people who, from their normal physician, were taking the maximum amount of gabapentin. I think it's something like 300 milligrams 3 times a day. So you've got somebody who's on the maximum dose of gabapentin, and then they're getting this cream that has, 200 milligrams. And each day that they're taking it, they're building up this toxicity that they don't even know about. And the doc who wrote the order has no idea, because the doc who wrote the order is just signing an order. He or she has never met the patient, have no idea what the other prescriptions that the patient may be taking or anything like that. So, these are long-term issues that go on. I'm still and will always be boggled by the fact that when a claim for reimbursement comes in for an item, service, or a procedure, and the referring or ordering provider is someone for which there is no prior E&M in a timely manner. If you're going to write a prescription for a patient, or you are going to write an order for DME or genetic testing, there's your 3, right? COVID-related stuff, genetic testing, your lab stuff, DME. How is it that these claims aren't just being stopped right there? Like, how is it that the analytics aren't catching that? I mean, none of us know the answer to that, but certainly.
Well, I think there is an answer. Right? Because typically the claims get caught based on edits in the system, right? So if there's no edit created,
right,
well, or there's no flag, right? I mean, obviously, I'm using my experience to, come up with a hypothesis or a reason why, but
right. Yeah, I mean, that's the obvious answer. But I think that, When I read this report, it was interesting to me that there were that many providers that used telemedicine. That's great. It's an important factor, right? It helps to reduce some of those social detriments or social determinants of healthcare. It definitely helps with that as an issue, right? The ability, if you're homebound, to still get quality care that you need through a telemedicine visit, get the prescriptions you need, all of that. Those are important and those are great factors. But I think that to say only 1,700, and which is fine, but to then have some clickbait article that says, oh, the OIG found that telemedicine fraud is rare is just an absolute. It's not even accurate, right? Because why
No.
would we be seeing these roundups that are occurring where there's $1 billion in healthcare fraud that's tied to tele fraud? The three of us talk about it on an incessant basis. We're presenting about it, we're talking about it, we chat offline about it. The OIG puts out on probably, it seems like it's nearly a weekly basis on social media. They're putting something out regarding telemedicine fraud and identity theft as it all connects. So I just think that when people are reading the OIG reports, you have to read it for really just what they looked at. You can't really go into anything outside of what they looked at. It's OIG reports are very, very narrow in focus. They're specific to what the issue is at hand. But then you go and you see these clickbait websites, which just really get me. I was so torqued up because I was like, oh, it's rare. And then you read the article and it's like, well, you guys you're just playing the game. It's like when a politician has a 90% favorable rating, someone's going to say, oh, he has a 10% unfavorable rating, right? It's all a matter of how you look at it. But to say that the fraud in telemedicine is rare is just disingenuous.
No,
It is. Go ahead, Jordan.
No, I mean, I was going to say I agree, and I think that's a problem with a lot of these reports. And unless you have, that's another reason I like doing this show, but somebody to help keep that in context. A lot of people read these things as like the clickbait stuff or the quick data, and then they apply it to everything and they run with it. And I think that's, that's problematic. And kind of speaking of the clickbait stuff to roll into something, Sean, I know you wanted to talk about is the clickbait that I often get. When we're doing an audit or an investigation is the dreaded compliance plan. And my clickbait is, hey, we got a $1,500 one that a consultant sold us. That was a cookie cutter, beautiful compliance plan. And I'll let Sean set the stage, but I think the compliance plan as the OIG, CMS, and these payers are going to really and are ramping up these audits, the compliance plan is going to become a point of focus and something that they're going to drill down and something that can save you and hurt you if you don't use it properly. So, Sean, I think you and Eric go for it and set the stage on this.
Yeah, I mean, for me, it's pretty simple, right? I get a lot of phone calls, and the last thing that I need is somebody wasting my time. You know, for me, if somebody's going to reach out to me and you're going to pay the money to have somebody like myself or Eric perform a gap analysis of your organization, make a determination as to where the, problems lie, and then develop a plan, develop policies and procedures, and then not implement what it is that you've asked us to create, and you want to stick it on a shelf and let it collect dust and hope that in the event you get a CID, a civil investigative demand, or something else is going on where a UPIC is looking at you, or there's a revocation of your Medicare provider number, or whatever it may be. The medical board is looking at you and you think you're going to pull this compliance plan off of a shelf and hand it to them. I mean, we had a situation not too long ago where, I had a couple of, former clients that I've not heard from in a year and a half, 2 years, reach out and both indicate that, they needed me to write a letter on behalf of their organization that their attorney could use to go back to the OIG or to the DOJ, whoever it was, to say that, they've created a culture of compliance because they hired our organization and we did a gap analysis and we built a compliance plan and we built policies and procedures. And I had to remind them that the plan that I had sent them had never been reviewed by the organization. There's a dozen emails from our organization to you saying, we've got to get the edits back. It's watermarked as draft. There's nothing that I can do. You have literally taken whatever money you paid to me to build this for you, and you have thrown it out the window. You would have been better served to go and play craps in Vegas. I mean, there's nothing that I can do. I mean, Eric, you're a retired investigator, law enforcement officer. What are your thoughts on that?
I mean, if I'm doing a subpoena and I'm the OIG agent and I'm either doing a subpoena or a search warrant and I'm finding a policy that's in draft and someone is relying upon it, that's missing the mark. We talked a little bit about this before we jumped on live. And, I worked on a project recently with a pharmacy that had an outdated compliance policy with respect to copay collection. And they had a draft policy that was never implemented. And somebody in the pharmacy was using the draft policy. Somebody else was using the existing policy. So there was no consistency across the board on those things. If you're going to have a draft policy and you're not going to implement it, it's as if it doesn't exist. Because until it's been executed and there's something that says, revision date, and it's signed off on by whoever has to sign off on it, it's nothing. It's just a piece of paper. It's a talking point is really all that it is. Now, does that get you out of a criminal issue if the policy is relative to something that ultimately is your criminal? It might get you out of the criminal issue because you're saying, hey, look, we didn't have any intent. We were working on this policy, but it's not going to get you out of the civil part of the knew or should have known. You're clearly going to have a problem with that. But to spend the time and effort to come up with a policy and then not implement it, you may not like the policy. And I say it all the time, like, you may not like what I'm going to tell you, but you're going to respect it because you're going to know where you're coming from. And I think that's an important piece of that.
No, I think it gets missed a bunch. I mean, one of the biggest parts is too, and we'll go in, and if we look at a compliance plan, is to see the one, to your point, Eric, that was signed off on in 2003, and hasn't been updated since 2003. And then with all the electronic SharePoints and things like that these hospitals use, so a lot of institutions have gotten away from like the 3-ring binder, like Sean mentioned, that's sitting away on a desk with all your policies and procedures, and now it's on this intranet of the hospital. The problem with it being on the intranet of the hospital is then staff and administration forgets that, hey guys, you're supposed to actually review the compliance plan. You're supposed to update the policies and procedures. There's supposed to be a mechanism that the policies and procedures were actually communicated to staff. And then to your point, things will either sit in draft, not be signed, and you're better off not having, in my mind, not having anything at all than to have that mixture of misinformation, duplicate information, or just outdated information. And that's the problem that I often see when we go in and we look at this.
So, my experience, and Eric, again, as a retired, OIG officer, right? Investigator, agent. For me, I tell people all the time, it's got to be a living, breathing document, right? Yep. This compliance is a journey. It's not a destination, right? It's always evolving, to Jordan's point. We're always updating policies, always updating procedures. The plan, for the most part, remains stagnant, right? Unless there's a dynamic shift in the structure of the organization itself, right? We're going from an LLC to a PC, or from a PC to an S Corp or C Corp or something like that, where, the structure of, accrual-based accounting versus cash-based accounting changes, our cost report, process has to change. So what I tell people all the time is this: listen, and to Jordan's point, if you're not going to put the effort into ensuring that this thing is a living, breathing document and that you are doing the necessary that is required to demonstrate good faith efforts and a culture of compliance within your organization from the top to the bottom. To Jordan's point, I tell people all the time, you're better served to have nothing at all, because part of your negotiation can be, heck, we'll enter into a monitored compliance program, right? A corporate integrity agreement. I mean, what are your thoughts on that?
Well, I think that you've got two things. First of all, when a provider gets themselves in trouble, the first thing that they want to do, right, when you've got your self-disclosure protocol in there, is you're always talking about what was the thing that went wrong, how did we find it, what did we do to stop it, and then more importantly, what are we doing to ensure it doesn't happen again? And that's where your corrective action plan comes in, right? And the thing about a corrective action plan is that's the one that's the least costly, because you can set that in motion yourself. You're in control of it. You run it. You do all of that. The thing that everybody wants to stay away from is a corporate integrity agreement. It's invasive. It requires frequent reporting, typically quarterly plus a yearly report. It's multi-year. And, you don't want to get into that situation. It boggles my mind that providers will spend the time and effort to have Sean Weiss put together a compliance program, and it remains in a draft form, which essentially makes it unusable. You can't rely on it. You can't rely on something that has draft written on it for anything. And it'll never fly, right? So you can,
Yeah. Yeah. I mean, so look, I agree with you. CIAs are invasive. As somebody who serves as an IRO, as an independent review organization, you're right. It is a ton of work. I just got done doing one for a group in South Texas through Lyles Parker. And I mean, my report was 60 pages, without the statistical analysis for sampling, the rat stats, the explanations, all the things that we had to do. And it's tens of thousands of dollars every quarter that has to be paid. My rationale, Eric, for why I brought up that as part of a negotiation, you can say I'll enter into a monitored compliance program, is to try to sway the OIG from escalating it to the Department of Justice to where it could go from a civil matter to something that could become a criminal matter, right? And because if you think of a mutual friend of ours,
happens though in a self-disclosure,
well, I mean,
you don't really see that happen.
Well, I'm not talking about a self-disclosure. Remember, I'm not talking about an SDP. So if you think about our mutual friend, Jose Vela Jr., okay, former prosecutor. For Jose, 85% of the cases that came through his office that started off as civil turned into a criminal prosecution or turned into a criminal matter, not necessarily a prosecution. They either, entered into a plea agreement, a settlement agreement, whatever it is. My point of saying that is that, providers look, you never want to have to call me or Eric or Jordan when you're on the backside of a problem, right? You got to be proactive. You got to look at this stuff not in a vacuum, but as a fabric of your organization. And it's got to be part of something that you do each and every single day. Otherwise, what's the sense? But you're right. It boggles my mind when I have groups call me. I can't tell you how many groups have called us over the years and have asked us to build a corporate compliance program for them. And we put something in there as a disclaimer that says, if you fail to monitor this because we're not doing it for you as your third-party outsourced compliance company, it is up to you. And if you don't update it, you might as well trash it because things change. Think about in 2022 and again in 2023, Stark and anti-kickbacks have all changed. I mean, you've got to revise those. We went through COVID. You had to have policies and procedures to comply with COVID, with the 1135 waivers, the PHENs, the waivers go away. Now you're back to the restrictions that originated prior to it. I mean, this is not something that you can just kind of go, we'll do it one time. We'll pay $5,000 and be done with it. It doesn't work that way.
No, it's not a checkbox, and people got to get out of that mindset. And if you treat it like a checkbox, and then you get in trouble, then it's too late. So, well, listen, I guess with that said, dude, we never get the whole. I feel like we never, it's like Eric always says, we're not going to get to everything, and then it's like, yeah, we definitely don't get to everything. The hour goes by, and too much fun is had.
Like sands through the hourglass, so are the days of our lives.
I was waiting for something like that from you.
Now listen, with that, we will end on that high note. We appreciate everybody for joining. Thanks for taking the time. Thanks for sending us some of the ideas. As always, we'll be back again. You'll see the invite come out, and we'll be back again. But thanks for everything that you do. If you do see some of those healthcare professional workers, tell them we appreciate them. Tell them that we love them. Thanks for all that they do. Thanks again for hanging out with us. And then, Eric, you sign us off with Sean's famous quote that I got to get a T-shirt made for, by the way.
Oh, we got to get that's going to be the next original hashtag
T-shirt.
CCC. It's always going to be good to yourselves, but be good to each other.
There it is.
I know I got to close. I know
Y'all don't care.
I know it's close.
You're close. I'm not going to correct you this time. You did a good job.
Good job.
More importantly, be good to each other.